Hi, everybody. Dr. Scott and I are here today. We're so excited to talk with you about all things hormones. And today we're going to answer some questions that have been submitted to us regarding hysterectomies, like kind of what they are, why do we have them? Are they a good solution for the menopause symptoms that you're having? And Dr. Scott, I'm so glad to see you again. How have you been?
I've been really well. I so look forward to these talks with you because one, you and I just enjoy spending time with one another.
Yes.
And also because we are bringing really valuable information
Yeah.
to people who may not be able to find this information in
Yeah.
other places. And as there are a lot of different options out there in medicine, and I think what you and I try to do is to bring a nice combination where we're blending the best of natural and then mainstream medicine. And don't get me wrong, if I break my femur, I want general anesthesia,
Yep.
a titanium rod, and a steady-handed surgeon.
Yep.
For so much of other parts of life, I believe that mainstream medicine is a little misguided, just reaching for drugs. And as we know, there's so much that we can do to optimize your health
Yeah.
without using drugs or
Absolutely.
surgeries.
Absolutely. So, I guess to start the conversation, I want to share a little bit about my story. And then I think it's a very good teaching moment for people.
Mm-hmm.
I was 45 years old. I went to see my gynecologist because I had been having heavy bleeding. And so, what I've learned in the last month as I've been researching this is that what I was having was irregular periods. I wasn't having heavy bleeding. I just wasn't bleeding the 3 days. I was bleeding seven, and I was
Mm-hmm.
bleeding every 3 weeks instead of every four. What I thought was heavy bleeding really was, I know now, was not. But the solution for me was we did a little bit of testing. She did a biopsy, she did an ultrasound, and she did something else. I can't remember what it was now, but the determination was that I needed a hysterectomy. So we went in, I had the hysterectomy. When I came out, she said, we decided to do a full hysterectomy. We took out your cervix, your uterus, your fallopian tubes, and your ovaries, because now you don't have to worry about any of those cancers. I was like, okay, that's fine. I didn't know anything about it. I didn't even know what it was supposed to look like. And then years later, I realized now, it's 20 some years later, I realized that was pretty extreme for a girl who was in perimenopause, just having irregular periods.
Right.
So,
And by definition, Tina, that sent you instantly into menopause.
yes, it did. And I really got a lot sicker. I felt well for the first year. I was on estrogen at the time, and then they took me off the
Mm-hmm.
estrogen. And then my health really declined after that.
Yeah, I'm
So, what?
sorry you had to, hopefully, sorry you had to experience that. I think that if this talk that we're putting on today helps even one woman to
Not
have a
do
better
that.
understanding of what uh, her body is doing and what she has the power to be able to self-advocate
Yeah.
for,
Yes.
I think that I'd call that a success, right?
Yes, I agree. And because that's what we want, right? Is we want people to be empowered. We want them
Mm-hmm.
to know the questions to ask when they go to the doctor,
That's right.
and to be able to understand that heavy bleeding is something that soaks a pad or a tampon every hour for several hours.
Mm-hmm.
Or, it's like there's just so many things, Dr. Scott, that we're not taught, and especially back in my generation, no, it was something we didn't even talk about. So
Right.
I'm excited for the women of this generation, these
Yeah.
generations, where they're able to talk about this and it's becoming normalized,
Mm-hmm.
which is how it should be because it's a normal part of a woman's life.
Right.
What?
So I'd say to the viewers, get your notepads,
Yeah.
because we're going to be covering quite a bit of stuff here. And hopefully in the next, 30, 40 minutes or so
Yep.
that you and I talk, we'll be able to cover all the different components so that anybody watching this will have the tools to best understand what you and I would probably agree to is a most practical approach.
Yes. Yes.
Because clearly at a certain point it becomes a problem. So I think a good place to start, Tina, would be here, which is let's start with some basic definitions,
Okay.
right? Because to a gynecologist, there are a lot of people who use the word hysterectomy or full hysterectomy, and I just want to take a moment to explain what that is.
Okay.
So, hysterectomy by definition is removal of the uterus.
Okay.
Okay. Now, even that has different subsections because in certain instances, if the surgery is done through scopes, a woman and her doctor might choose to do a supracervical hysterectomy. That means to
Okay.
take out the uterus, but leave the cervix.
Okay.
And I think that there is There's certainly benefit in leaving the cervix in terms of maintaining some
Yes.
anatomical support and decreasing prolapse
Mhm.
risk. There are a number of women who describe sexual stimulation from contact with the cervix.
Mhm.
So a hysterectomy by itself refers to removal of the uterus and or cervix. And
Okay.
typically, if it's a full hysterectomy, it would include a uterus and cervix.
Okay.
There's a distinction between that and also taking the tubes and the ovaries, and that's known as an oophorectomy.
Okay.
So if, in your case, you had it done through your belly, is that right? Did
Yeah.
you make an
An
incision, like a
incision.
horizontal incision?
Yep.
So you had a total abdominal hysterectomy
Yep.
and bilateral oophorectomy.
Wow.
So I just want to be clear in the fact that there are a lot of women out there that say, "Oh, I had a total hysterectomy." You can see that doesn't really tell what was exactly
Yeah.
removed. And I think
Yeah.
the first thing that for the women who've actually had this procedure done, you should know exactly what structures were removed. So that's just a little bit of a semantics just to make sure that
Mhm.
we're talking about everything
Yes.
correctly. Let's do this. Let's you and I take a step back and begin to examine what the problem is, because I think that when you have a good understanding of what's driving the issue,
Mhm.
it gives you better tools by which to address it.
Yes.
So, to begin with, in broad and general terms, there are two different causes for what is known as abnormal uterine bleeding. And
Okay.
that's what you were describing to me, which was abnormal uterine
Yep.
bleeding. So let's contrast that to normal uterine bleeding, right? It's a good place to start. Normal uterine
Yeah.
bleeding is a woman who has a menstrual cycle that comes typically about between every 26 and 30 days. It's characterized by an ovulatory surge in the mid portion of the cycle. And typically, I'll put it in air quotes here, a normal menstrual cycle loses about 80 cc's of blood.
Okay.
It lasts for maybe 4 to 6 days. Most women have 1 day of a little bit of spotting or light bleeding, then followed by 3 or 4 days of heavier bleeding, and then things end.
Mhm.
So that's what a typical cycle is. I would say that to some degree of discomfort and cramping is normal. But if your menstrual bleeding is keeping you missing work,
Mhm.
curled up with a cup of tea under a blanket on the couch, unable to get through your life, that's probably not a normal menstrual cycle.
Okay. Okay.
So I think that's a good place to start. And then what happens is this: as women typically get into the later states of their reproductive years. So as you and I know, it's like women between probably ages 18 and 28, those are probably the most fertile
Yes.
times in a woman's life. And because the eggs that are in your ovaries were actually there before you were born.
Yeah,
So
that's
when you were
crazy.
in your mom's womb, you were part of a cluster of 200,000 different eggs. And over the course of a woman's reproductive life, about 500 of those ovulate. They come to fruition
Oh,
and
okay.
produce an egg. And if the egg and the sperm are all together in the right place in the fallopian tubes, conception occurs and there's a pregnancy. As women enter into the later years of their reproductive years, and I would say that's probably starting, the earliest is probably about 35.
Okay.
That as women start to get into their 40s, we start to see some changes in their ability to ovulate as efficiently as they did when they were 25. Notice I'm choosing my words really carefully here,
Yeah, I see that.
because I'm not saying that a woman is not ovulating well. I'm not saying she can't get pregnant. All I'm saying is that energetically, statistically, that as women get up into their 40s, it becomes a little more difficult to
Mhm.
get pregnant. And that's probably because you've had these eggs in your body at this point for 42 years or whatever it is, as opposed to
Yeah.
when you're 20, you've had these eggs in your ovaries for 20 years. What happens is as women get into their later reproductive years, we'll just say maybe age 40 to 50, two things happen. The first is we start to see more anatomic changes. And when anatomical changes, things like polyps and
Mhm.
fibroids. And let's even take a step back and clarify the difference between those two structures. All right. So a fibroid is a typically, although not always, benign tumor that arises from the muscle layer of the uterus.
Okay.
A polyp is it's like a glandular growth that
Okay.
arises in what's known as the endometrium. And the endometrium
Okay.
is the
Yes.
lining of the uterine cavity. And the endometrium is what sheds off every month,
Okay.
right?
Hmm.
So what happens is as women get a little older, we start to see a greater prevalence of the growth of polyps and fibroids. The other thing that happens is as women age and as their ovulatory cycles are a little less efficient, again, I'm not saying that you could get pregnant, we begin to see that developing ovary produces something known as the corpus luteum, means yellow body. And what this is a structure that forms on the ovary that then secretes progesterone in the second half of the cycle. And as like you would graph progesterone over a cycle, in the first half of the cycle, it's almost immeasurable. Days 14 to 28, it rises up and comes back down.
Yeah.
And what we know is that decline in progesterone as that corpus luteum ages, as pregnancy doesn't happen, that's what tells the uterus to shed the lining. So what happens is as women age a little bit, their production of progesterone isn't quite as efficient. And this actually makes a really good case for women as they get into their late 30s and early 40s to work with their doctors to maybe augment a little progesterone in the second half of the cycle when they're trying to get pregnant.
Yeah.
Because I believe that this helps to support the developing embryo. And I think the reproductive endocrinology literature supports that. So what happens is as women begin to age a little bit, they don't make quite as much progesterone in the second half of the cycle. That second half spike isn't quite as high, but for a lot of women, they still maintain a static level of estrogen production. So what estrogen is a trophic hormone, meaning that it causes tissues to grow, all right? What happens is progesterone is the yin yang of estrogen. So if estrogen is telling tissues to grow and thicken and become more lush, more blood filled, more fluid filled, progesterone's putting the brakes on that a little bit. What happens is in women, as women get into their 40s, we see more of this state of estrogen dominance. We see a greater sort of unopposed growth of the lining of the uterus. And then as that lining of the uterus has become almost a little overgrown or imbalanced because of less progesterone in the second half of the cycle, that causes more bleeding. So one of the more common causes we see of heavier cycles as women get into this age group is due to an estrogen progesterone imbalance. So what I'm trying to stress here, which is really important for your viewers, is that broadly speaking, there are two different categories of abnormal uterine bleeding. There is a hormonally mediated abnormal uterine bleeding that is typically characterized by a high estrogen to progesterone ratio. And then there's an anatomic abnormal bleeding, which is characterized by the presence of polyps and of fibroids as well. And what we can do is in a little later in this talk, if you know, we can go into what some of the different characteristic bleeding patterns are for both of these different kind of anatomic findings. So before we overwhelm everybody with too much information, how are you doing? Are you following along? Is this all making sense?
Yes, it does make sense. And I think the interesting part is to think that there are two reasons for it. I'd read about the polyps and the cysts and understood how they cause the bleeding and then about the hormones. But how do you determine? This is what I'm wondering. So how do you determine which one it is?
That's a very good question. You do it in part from the history.
Okay.
So it's the old school medicine of doing a history and a physical examination should be a part of every woman's visit with her doctor.
Yeah.
And if your doctor doesn't take a careful history, if your doctor doesn't look with the speculum at your cervix, and make sure that your pap smear is normal, because remember, we're talking about abnormal bleeding in regard to things that come from inside the uterus, whether it's a fibroid or a polyp. There are women that have abnormal uterine bleeding from a cervicitis, which is an inflammation of the cervix, or a cervical cancer.
Okay. Yeah.
So if your doctor gets you into his or her office, says, oh, let's just order an ultrasound. Oh, you got some fibroids. Let's just get that uterus out. It's just problematic. And they haven't actually taken a speculum and looked at your cervix, find another doctor. They're not doing a thorough evaluation of what's going on.
Yeah.
So let's do this. Let's take the lower genital tract stuff out of the picture right now. Let's assume normal labia, normal vaginal tissues, no evidence of a vaginal infection, and no cervicitis or cervical cancer, right? So now that leaves us all above the cervix in the uterus, right? So what's the next step? The next step is to do what's known as a bimanual examination. And that's an exam where two fingers are placed vaginally, and then another hand is placed over the pubic bone. Just try to get an idea of the size of the uterus and its mobility. So these are all important components. And in my practice, every woman who came into my practice who was having significant symptomatology, I felt that doing a rectal examination was an important component of it as well. And I know it's never comfortable to have a finger put into your bottom,
Yeah.
but it lets the provider get a good assessment of what's going on, what's known as the cul-de-sac, which is the lowest part of the abdominal cavity, because nodules and endometriosis and tumors and things like that reside there. It's just a way to be thorough in terms of one's evaluation of your patient, because my belief is if you're even considering bringing somebody to surgery, you want every available piece of information at your disposal before she goes to sleep and before you start. And I can tell you that there are a lot of doctors that are heading, I don't want to say blindly, but without all the information that they need as they go forward with the surgical procedure.
And what a difference to understand why you do certain things in an exam.
Mm-hmm.
How different that would make a woman feel to understand that this is why we're doing this. This is what I'm looking
Right.
for. And it would help that comfort level, like some of that anxiety would probably lessen for most people because it
Mm-hmm.
is a bit uncomfortable. You're with someone you don't really know, and it's a very private part of our bodies, right? So
Right.
it would help. It helps a lot to understand that's why that type of exam is being done.
Mm-hmm.
So I appreciate that very much.
And I think it's an important part of the exam. And I think that from the provider standpoint, I don't like having a finger put in my bottom. I've had my prostate examined by my doctor. And what I would always do would ask permission. And I'd say,
Mhm.
do I permission to put a finger rectally? I'm going to put a finger vaginally as well. That allows me to ensure that there's no nodules, tumors, masses,
Mhm.
anything that I might be looking for in that cul-de-sac. And I think that's just an important part of the communication.
Yeah,
Is from my perspective, I was really wanting to know that I was going into my decision making, and I'm not saying just a surgical decision, with my eyes wide open,
right.
get as much information as possible. But you asked me just a minute ago, like, how do you make that distinction
Yeah.
between anatomic and hormonal?
Mhm.
And that's a really good question. So let's talk about that. So you've gone to the doctor, and the first thing your provider should do should be to take a good history.
Okay.
Now, what that history should investigate should be the character of the bleeding. So if a woman came
Okay.
into me and says, boy, doc, over the last year, I've had more pressure on my bladder. I feel like there's a fullness in my pelvis. My periods are crampier and heavier. I feel like I'm losing a lot more blood. I might be thinking in my mind's eye that she could have a fibroid, a space occupying
Okay.
mass
Okay.
that's in her pelvis, that's pressing on her bladder or pressing on her rectum, or just filling up the space and causing some discomfort. Additionally, bleeding that's associated with fibroid tumors, and remember, these are the tumors that are typically benign, but they're found in the muscle layer of the uterus. The bleeding happens with the menstrual cycles. When a woman is describing intermenstrual bleeding, so it's, doc, I have like a period, a usual period time as we discussed, but then mid-cycle or a week later, I have another day of spotting and I have to wear a pad or something like that. That's how a polyp behaves. All right. So I think the most important thing that a woman should do would be, number one, go to a doctor who's going to do a good physical examination and take a good history. If your doc's not doing that, I'd say run away. Number two, the next step would probably be to examine the pelvic structures with an ultrasound. Now, the best ultrasound technique to look at pelvic structures is a vaginal ultrasound. Again, if your doctor is just putting the transceiver over your belly and looking transabdominally, they're decreasing their ability to visualize these structures by about 70%. Makes a huge difference. The other thing that's really important, and everyone should be writing this down because I know that there's someone out there whose doctor has scheduled you to have an ultrasound in the second half of your cycle. And that is wrong. So an ultrasound needs to be scheduled in maybe about the first 5 or 6 days after completion of a period. Why is that? Because this lining, this endometrial lining of the uterus has been shed. Remember, under the influence of estrogen over the course of the month, this lining of the uterus gets thicker and thicker. So what happens is if you are doing an ultrasound in the day 24 of a woman's cycle and you see a thickened lining of the uterus, you don't know whether that's thickened from a diffuse exposure to estrogen or if actually that lining is supposed to be thin, but there's a space occupying polyp that is in there. So this is really important. And I can't tell you how many women I've seen go down this slippery slope that ends up with a misguided surgical technique.
Yeah.
Because of something simple as the ultrasound was done in the wrong time of the cycle. So get out your notepads like the week after you finish your cycle with one caveat. If you're bleeding all the time, 28 days a month, never stops, go to your doctor. We're going to get whatever information we can with the ultrasound. And I actually had a patient at one point who So a normal hematocrit, which is a measurement of how many blood cells we have in
Mhm.
our body, is 40%. She bled herself down to a hematocrit of 10% because her friend said, if you're bleeding, don't go to the gynecologist. They can't do an evaluation on you if you're bleeding. A hematocrit of 10% had her about this far away from probably having a stroke or a heart attack. And she needed a blood transfusion. So the caveat to that is get your ultrasound done in the first week after the completion of your previous cycle. If you're bleeding all the time, every day, it just doesn't stop. Just get an ultrasound. We're going to do it.
It's interesting. I have a friend who, when she was in her 40s, she would just bleed like randomly. And I remember being at the store with her once, and she was just walking in front of me, and suddenly her pants were just covered.
Oh, I'm so
And
sorry.
she had I know it was terrible for her. And I just never even knew that was possible to happen to someone. And so that type of bleeding, that is something what is that attached to? Is that a hormonal thing, or is that an anatomical thing, or could it be either one?
It could be either or a little bit of both.
I think hers might have been cysts or fibroids, maybe,
Mm-hmm.
but I'm
Mm-hmm.
not positive. I don't know. I just remember the bleeding was horrific, and she was afraid to go places, and the
Oh,
anxiety it caused.
oh, I'm
You
so
know,
sorry for her. Yeah,
yeah, it was hard.
and hopefully she got that figured out pretty quickly because that's a very embarrassing situation to
Yeah.
be in.
It was
Um,
actually took quite a while for her to get it figured out, but then she never did have a hysterectomy. And I don't remember honestly what the result was, but I know she did get it under control at some point. But
so
it
we
was a
started
while.
talking. We started talking just a second ago about ultrasound, right?
Hmm.
And the most important rule is get your ultrasound done in the right time of your cycle.
Hmm.
Because for a lot of women, if you can do that ultrasound in the early part of the cycle, you might see that the lining of the uterus is thin, but there might be a thickening up at the top of the uterine lining. And that's when you go, oh, that's probably a polyp. Now, if your doctor and your ultrasonographer is really good, they will do something which is known as a fluid contrasted ultrasound
Okay.
or a saline infusion sonography, so SIS. What this does is ultrasound was discovered in the 40s to identify German submarines. So ultrasound works really well around water, right? So what happens is if you, while doing an ultrasound, infuse a small amount of water, sterile water, into the uterine cavity, and I'm talking a couple cc's, what it does is it can outline the exact anatomy and the exact position of a polyp, and it also helps to designate whether the degree to which a fibroid might impede on this endometrial lining. So if you've got a good doc, they're doing a fluid contrasted or infused
Mhm.
sonography, because that's going to tell them exactly what they're looking for, the size of the polyp or the fibroid, and the degree to which it impacts or impinges on the inner part of the uterine cavity. Because there are a lot of women that have fibroids that are out on the outer part of the uterus, nowhere near that inner endometrial lining.
Okay.
And those can create problems by mass effect. In other words, you could have a big fibroid, like an 8 centimeter fibroid that's on the outer part of the uterus. It may not be affecting your bleeding, but it can certainly be affecting all those other things we talked about, like pain and discomfort, cramping, and a mass
Right.
effect,
And
pressing on the bowel bladder.
you just outlined what you said, like an 8 centimeter. That's the size of
Eight
a
centimeters.
softball,
8 centimeters. I'd say
baseball.
8 centimeters might be a baseball.
For the
Yeah.
people who don't see the video that are
Yeah.
just listening.
Softball is probably
Wow.
12 centimeters.
Okay. So that's a really good gauge too to understand the size. 8 centimeters
Mm-hmm.
is a baseball, 12 centimeters would
Mm-hmm.
be closer to a
But
softball.
remember, what's
Wow.
really important is to consider where, if there is a fibroid, where is that fibroid relative to the lining of the uterus is the next question that needs to be
Okay.
asked. Because there are a lot of women, I would say, if I can think back of when I was doing clinical medicine, I did all my ultrasounds myself. And
Okay.
I did these fluid contrasted scan, and I actually had a screen up behind me where, as I was doing the ultrasound with the woman's head tilted up in the bed, I could point out to her exactly what we were looking at. So she left that clinical visit saying, I've got a zero point 0.8 by 1.2 centimeter polyp at the top of my uterine
Yep.
cavity. I've got no
I
fibroids.
saw
Everything
it.
looks normal. We're going to go to the OR in a couple of weeks and we can take out the polyp under direct
Yeah.
visualization. Problem solved.
Yeah, she saw it. She understood what was
Right.
happening. And then you don't spend all this time wondering if you're being fooled.
Or
Yeah.
just fretting about it. You know what
Yes.
it's like when you're getting an
Yes.
ultrasound done with the sonography tech and they're looking at things and blowing things up and you're like, what are you seeing? And they say, I
Hmm.
can't tell you.
I can't tell you. Yeah. I can't tell
right?
you.
But I'm a medical doctor. I'm doing the scan. I can show her exactly what I'm looking at. And I felt that was really valuable. So I think the saline infusion sonography is super important. So we talked a little bit about polyps.
Mm-hmm.
Now, in terms of surgical approach, I know we started talking about hysterectomy
That's
at the
it.
beginning of this,
That's
but
where we're going. That's where we're going because this is what
what
we
we're
need
doing
to
is
know.
what I'm hoping people to recognize is that there's a lot of different places to intervene that don't necessarily require a
Mm-hmm.
hysterectomy. So let's just say that you've got a savvy doctor and he or she has done a fluid assisted ultrasound. And you know that there's a little 8 millimeter polyp up at the top of your uterine cavity that's contributing to this intramenstrual bleeding. The best way to resolve that is through a procedure known as a hysteroscopy. And that's just a little scope that gets placed into the uterine cavity. You can see the polyp under direct visualization and you pull it out. It's really that simple and the
Wow.
problem goes away. If anyone's doctor is making a recommendation for a blind D&C, find another doctor. So D&C is a dilatation and curettage. This is a
Mm-hmm.
blind procedure. There are still doctors out there that for abnormal uterine bleeding are doing a D&C. And
Yeah.
don't get me wrong, there are a few select people who probably need to have a scraping out of the lining of the uterus for various reasons. But that should not be the first step, because I've seen any number of people that go into their doctor, they've got a polyp, the doctor does a D&C. Remember, it's a blind procedure.
Mm-hmm.
You're doing it by feel. And guess what? The doctor misses the polyp.
Mm.
So you've had anesthesia, you've had a procedure, pathology comes back negative. The next month you start having intramenstrual bleeding again because the polyp wasn't taken care of. So the modern doctors are doing this under a direct visualization, putting a hysteroscope into the lining of the uterus, observing the polyp under direct visualization and excising it out. And in my surgical practice, I'd send my patients home with before and after photos. So look,
Yeah.
here's what you're looking at before, here's what we're looking at after. You can see it's no longer there.
Yeah.
Just my belief was to try to give people as much information as possible to make them best stewards of their own healthcare.
That
So,
doesn't surprise me about you because that's exactly what you always do. You
yeah.
always want us to have all the information, which is why we've been so excited about doing these podcasts with you, because your wealth of knowledge after so many years of working with hundreds and hundreds, probably thousands of women over the course of time, you have so much experience with these kind of things, and we just don't have it. And it becomes a very emotional, it's a very emotional
Sure.
thing for a woman. Even if you don't want to have children anymore, women still, a lot of women really grieve over the thought of having to have a hysterectomy, not just the fear of what it might entail, but I don't know, we feel like it's part of our womanhood and heard a lot of different things.
Let me make one more point here before I
Yeah.
forget about it. Sorry to
Yeah.
interrupt you.
No, it's
And
fine.
that is that we were talking about polyps and how polypectomy is a pretty simple procedure. It's very safe and it typically solves the problem. Remember, I mentioned that fibroids can form in different parts of the uterine wall.
Yes. Mm-hmm.
They can form out on the outside. They're called subserosal fibroids. They can form actually in the wall of the uterine cavity. But it's not until they really begin to abut and to impinge the endometrium, which is the inner
Mm-hmm.
lining of the uterus that sheds every month, that they begin to cause problems. And depending on the size and the position and the location of those fibroids, there are a number of fibroids that can actually be taken out through the same hysteroscopic technique. Now it's a little more advanced,
Mm-hmm.
but I've taken out any number of fibroids without having to do a complete hysterectomy. So you can take the fibroids out through a hysteroscope, the bleeding gets better, and the woman is left with her uterus and her ovaries. I hope everyone who's watching realizes that this is really valuable information, because in the year 2024, there are still doctors out there who are doing blind D&Cs for abnormal bleeding.
Yeah.
Who
Yeah.
don't know how to do a saline infusion sonography or a sonohysterogram, as it's called. And they don't understand that if there's a small fibroid, and I'm saying under maybe a couple centimeters, that is impinging or fully obstructing this inner part of the endometrium, those can be extracted through a scope. You go home the same day, you have spotting for 5 days, and you are done with that problem. So what we've been talking about, Tina, are the anatomical
Right.
contributions, right? So we started saying, make sure that you look vaginally, make sure that there's no vaginitis or cervicitis
Mm-hmm.
or, God forbid, cervical cancer.
Right.
Then do an examination, take a good history to try to really focus on what's going on. If you need to get more information sonographically, do it at the right time of the month.
Yeah.
Don't waste your time doing it at the end of the month, because let me tell you, that is a slippery slope. And I see it happen all the time. And then if there is something anatomic which is impinging on the lining of the uterus, it can often be removed through a hysteroscopic procedure, which is an easy in-office or sometimes in-office, more commonly in the OR, same-day procedure.
Wow. Wow. One of the things I read about hysterectomies, which was a little bit of a shock to me, there's about 600,000 hysterectomies done every year in the United
Wow.
States. 600,000, which seemed like a lot to me. And then they compared it to the 40,000 hysterectomies done in the UK,
Mm-hmm.
actually in England. And this is maybe from a year or two ago, so 2022, 2023. And I was like, part of it maybe is availability of healthcare, of the ability to maybe we have a little more control over going to the doctor here.
Part of it's the size of the population too.
Okay. Oh, okay. All right. Because that was
But
concerning to me. I thought, what does that mean? Okay. That makes sense. The size of the country that we'd be working in. I gotcha.
sure.
Okay.
So we just got done spending the last 15 minutes talking about the anatomic causes
Yes.
of of abnormal uterine bleeding. Don't get me wrong, there are some women who have big fibroids that are impinging into the lining of their uterine cavity. They're of a size and a position you can't take them out through a scope. This is the kind of woman who does have a hysterectomy.
Okay.
Hopefully a hysterectomy without taking the ovaries. The research these days suggests that we want to leave the ovaries in place for
Yeah.
any number of different reasons. And there are women whose life is transformed by having a surgical procedure to remove this fibroid that's been contributing to pain, pressure, discomfort, crampiness with their cycles, and abnormal bleeding. It's not for everybody, but I can tell you that I have operated on dozens of women who literally in the recovery room look at you and say, that horrible pain I've had in my pelvis for the last 5 years is gone. Mm-hmm. Yes, I'm feeling groggy from anesthesia. Yes, I've got a surgical incision pain that I can feel, but that deep-seated, gnawing, cramping pain, why didn't I do this earlier? Mm-hmm. Right now, I hope you realize that I'm not advocating, I'm not saying that everybody needs to have a hysterectomy. If anything, right, what I'm trying to do is to say, get informed mm-hmm. and have a good understanding of what can be going on. So we just spent 15 minutes talking about surgical approaches. Mm-hmm. Let's do this. Let's go back to what we started talking about earlier, which are the hormonal mm-hmm. imbalances. So let's just assume a woman has no polyps and no fibroids and no cervicitis and no cervical cancer, but she's having abnormal uterine bleeding. Mm-hmm. Lacking those anatomical findings, that cause of that is typically hormonal. So remember, the hormonal condition that's precipitating that is a high estrogen to low progesterone okay. ratio, typically. So the next question you want to ask is, what causes a woman to have a higher amount of estrogen relative to her progesterone? Mm-hmm. So now we're putting on our functional treatment hats and saying, all right, what can we do to help this woman to get better without doing something surgically and without doing something medical, and God forbid, without starting something like birth control pills, although in a woman who has what's called dysfunctional uterine bleeding from a hormonal imbalance, birth control pills will probably fix it. I'm not advocating for the use of birth control pills because in my practice, I found that similarly, using bioidentical progesterone in the second half of that cycle helped to close that gap. Remember, progesterone started low in the first half of the cycle, rises up in the second half of the cycle. Yeah. As women's age and as their ovaries age and as their ovulation practices are a little less effective, that progesterone goes down, right? But you still have this higher amount of estrogen. So there are two functional approaches that we can do to address this hormonal imbalance. One is bring down the estrogen to change that ratio. The other is to bring up the amount of progesterone to change that ratio. Mm-hmm. So we can talk about both of those. The increase in the progesterone is actually pretty easy because that includes the use of bioidentical progesterone in the mm-hmm. second half of the cycle, typically 100 or 200 milligrams orally a night. And for a lot of women, that will help to stabilize that estrogen balance, rebalance that yin yang of estrogen's growth and progesterone's putting the brakes on that growth, and return them to more of a normal state of cycling. The other option is to start thinking about what can you do to bring down the estrogen. So what causes high estrogen in women? So probably the number one thing is obesity. It's extra weight. As we put on more fat cells on our body, fat cells are little estrogen producing factories. So what that is doing is, let's just say that someone's 40 years old. Let's just say her luteal phase progesterone rise is totally normal. She could be in an estrogen dominant state with really high estrogen because of a lot of extra body weight, or because she's not clearing that estrogen well. So how do we clear estrogen out of our body? Estrogen is primarily conjugated through phase 1 and phase 2 detox pathways. And we lose estrogen, conjugated estrogens, through our bowel typically. So let's just say someone's in a state of estrogen dominance and she has cycles that are happening that are heavier, maybe a little longer, a little crampier. She's bleeding for 8 days a month, for example. She's had an ultrasound in the right time of the month. She knows that she doesn't have a polyp or a fibroid. One option is to use progesterone. One option is to also be looking at the ways that we can help to detoxify these extra estrogen molecules. And some of the things we have at our disposal are things like fiber. So increasing the amount of vegetable matter, maybe psyllium husk in your diet. This helps to bind estrogen and bring it out of the body through the gut. Another molecule that might be beneficial might be something known as calcium D-glucarate, or known as CDG. And what this does is it helps to ensure that once estrogen is brought into its phase 2 conjugate, so what happens is anytime we need to detoxify fat in our body, and estrogens are fats, they need to go through phase 1 detox, which makes them more water soluble. And then they go through phase 2 detox, where they're tacked onto another molecule and excreted through the gut or through the kidneys. So this calcium D-glucarate helps to support the phase 2 detoxification pathway, because in some women who have an imbalanced microbiome or who aren't stooling at least once daily, they can conjugate their estrogen, like setting it up to set it out with our stool. If it sticks around too long, it gets re-assimilated back into our body. It's a process which is known as enterohepatic recirculation. And it's a way that we go through all the work to conjugate these toxins, but if we're not hydrated well enough, if we're not taking enough fiber into our diet, if we're not stooling on a regular basis, which is at least once or twice a day, those conjugated, now toxic molecules can get absorbed back into our body.
Into the body.
So these are some of the functional ways that we can go about actually bringing down our estrogen. Weight loss, fiber, hydration, whatever it takes to get you pooping on a regular basis, maybe increasing some oral magnesium. What else? We have some of these phytonutrients like diindolylmethane, DIM, that helps to drive estrogen down the healthier detox pathways. And then weight loss is one of the most important things, and making sure that your insulin is working well.
Yeah. Wow, that is really interesting, because I think a lot of us don't realize there's so many simple options to aiding this problem, making it a little bit better.
So let's just do this. Let's just, because we've been talking for a long time, let's wrap up on things. Because I know we've gone through a lot of data. People can watch this video again. I really believe that if you watch it again and take some notes, this is most of all that you need to really begin to get a better handle on what's contributing to your abnormal bleeding. Help to work with your doctor to assess it correctly. So if there's one woman who's watching this whose doctor said, yeah, why don't you come in next week and we'll do an ultrasound? And she'll say, wait a minute, doctor, that's day 25 of my cycle. Don't we want to wait until maybe day 6 or 7 after I finish my next period? At which point the doc will say, oh, that's not a bad idea. Let's do that. You might have just saved yourself from going down a really slippery slope of investigations, copays, biopsies that you didn't need. Remember that as a woman ages, that she ovulates a little less efficiently, and that with increasing obesity and less health typically puts women into an estrogen dominant state. And there are some pretty easy ways to balance that, as we just discussed. And one more thing is that for a lot of women, and again, I know I'm trying to stay away from putting on my medical doctor hat. There are a lot of women who, when they can't get this abnormal uterine bleeding from an estrogen dominant state under control with using a bioidentical progesterone, a really good option for a lot of women is to use the Mirena IUD. Not necessarily promoting it. I'm just saying that I have had any number of different patients who they get the IUD placed, they've got the benefit of the most effective contraception known, and across the board, that takes care of this hormonal imbalance by thinning out the lining of the uterus.
Yeah, that was what I had read
And
about.
I'm only including it just to be thorough.
Yeah. Yeah, I understand. No, I think that's great. I think this is wonderful information. And for those of you who have been considering a hysterectomy or you're worried about whether or not you're going to need a hysterectomy, this episode can give you the information that you need to go and feel empowered as you speak with your doctor. And also, I want to encourage you, if you do not feel like your doctor is listening to you or that they are not following some of the steps that Dr. Scott has outlined for you, do not be afraid to walk out the door and get a different doctor. It is really
Right.
important that you do not stay out of respect or kindness or people pleasing. Just make the
Mm-hmm.
decision that your health is what's the most important thing, and the best choice that you can make is to put your health first, and your comfort level is really important while you're deciding that. So thank you,
Yeah.
Dr. Scott, for your time.
Yeah.
Thanks for sharing your wisdom again. I'm excited to hear what people feel about it. You can find links to Dr. Scott in the show notes. You can also find links to the Happy Hormone Club in the show notes as well. We're glad to talk with you today. Have a great week. Talk to you soon.